Recording in progress.
Marcial, good morning. Morning, honorable members. Good morning to the DG and the staff from the department as well as the committee's support staff. Marcial, I think we are a quorum, so we can start. Can you please flag the agenda?
Good morning, Chairperson. Good morning, members, DG, and colleagues. I'll do so, Chair.
So to the honorable members, welcome to the Select Committee on Social Services. A warm welcome to the DG and the team from the department. And welcome to our support staff. Welcome to this Select Committee meeting on social services. Honorable members, the agenda is in front of us. Can I get a mover for the adoption of the agenda? Honorable du Plessis.
Chair, I move to adopt the agenda.
Thank you, Honorable du Plessis. Honorable Makwele.
No, thanks very much, Chair. Greetings to you, honorable members, the officials in the platform, everyone. I rise to support that we move with the agenda as presented before us, and thank you, Chair.
Thank you very much, Honorable Makwele. So the agenda is duly adopted. So we move over to the apologies. Marcia, can you please present the apologies?
Thank you, Chair. Again, good morning, everybody. Chairperson, we have an apology from Ms. Adrianse. She's currently hospitalized. We have an apology from the Minister who's currently abroad, as well as the Deputy Minister with an appointment in the Free State Province. Thank you, Chair.
Thank you very much, Marcia. Honorable members, the apologies was presented. Can I get a mover for the adoption of the apologies? Honorable Makwele.
No, thanks very much, Chair. I rise to accept apology, maybe first and foremost from honorable members, those that given apologies, especially just to say speedy recovery from to one of our own, Honorable Adrianse, who's always with us, working very hard. But also, Chair, if you will also, while I note also apology from Minister and the Deputy, I'm just bit, even though maybe they will clarify us that who's responsible person, because remember, the meeting of this nature is not just meeting. At some point, we'll need somebody with authority to clarify us. But other than that, especially with the minister's apology, with that one we accept, but maybe they will clarify us. In principle, Chair, I rise to support an apology, but with that rider a bit. Thank you.
Thank you, Honorable Makwele. Honorable Makwele and the honorable members, they have engaged me in terms of that. Must we postpone the meeting or can we proceed? And I indicated that we proceed in terms of the DG is here, so he is the administrative head. So he can, if we want him to take any decisions, he is the responsible person to do so. But if we did not proceed with the meeting, Honorable Makwele and honorable members, we would have been requested or able to only close our process later in December. And as the chairperson, I indicated to them that the DG is here. And if there is any political interventions that must take place, me as the chairperson can then engage with the minister, if that is fine with you, Honorable Makwele.
No, it's very fine with that explanation, Chair. As long as you, as the chair, you realize it before I raise. I really appreciate that. We'll then proceed, Chair. No problem.
Thank you very much, Honorable Makwele. Honorable Feni.
No, thanks, Chair. I just raised to support the adoption.
Thank you very much, Honorable Feni. Honorable Sibande, I see your hand is up. Any additions?
Ma'am, I'm covered by Honorable Feni. I wanted to support that we proceed with the meeting because the DG is here.
Thank you very much, Honorable Sibande. So we will now, the apologies is adopted, so now we will proceed to the briefing by the Department of Health on the annual report 2024-2025. DG, over to you and the team.
Good morning, Honorable Chair and honorable members. I'm trying to show my face. I've got a team here that is joining me, and I've got DDG Njogu, who is here with us, DDG Jeanette Hunter, a number of chief directors, including Ms. Zondi, who's going to lead us through the presentation. And without wasting time, and with the permission, Chair, I hand over to Mrs. Zondi, who will lead the presentation. Thank you very much.
Thank you, DG. The DDG may proceed.
Thank you, Chairperson. Thank you, DG. Good morning to the honorable members. I've just shown my face, so I'm just going to close my video for the network. And let me share the presentation. Okay, so to start with, we are presenting the National Department of Health Annual Report for the year 2024-25, and we reflect on our vision and mission, which is also reflected in the document itself. So through the background slide, I'm going to run a little bit quicker so that we can cover the content within the time. So, but also we do emphasize the fact that we have gone through a big deal of ensuring alignment as we develop our annual performance plan by ensuring that we are aligned to the National Development Plan Vision 2030, but also taking into account the medium-term development plan 24-29, which outlined the 4 priorities, and it has got the indicators that we must make sure that we take care of when we do our annual performance plan, and as well as the Presidential Health Compact, that 2024-2029 that we have also taken care of. So in terms of the presentation, it's aligned to our 6 budget programs, which I will indicate as I go through. So this section is only going to cover the performance part, and in the midway, along the way, the CFO will then cover us on the financial information. So when we start with the first program, which is administration, so we had a target of unqualified audit opinion, which was achieved. We also had a target of 0 invoices paid after 30 days of receiving valid invoices from suppliers, and we achieved 99.8%. So here we only missed about 7 out of the 2,571 invoices that were paid after 30 days. And the reasons were because of the delivery note on the 3 payments that did not reconcile with the invoice quantities, banking details that changed and that needed more time to be worked on, insufficient quantities, and those things have been addressed now. And then When it comes to the health promotion messages, we had a target of 200, but we exceeded the target. We reached 671 due to increased some demand for support on activities related to the health awareness calendar, including the MPOX and multiple campaigns that were in for the year. And when it comes to the visits by the minister, the deputy minister, the DG and the DDGs, we had a target of 12, which was met. And then when it comes to the community engagements on health programs, we have a target of 2, but we exceeded that as we reached 14. And this included the community engagements with events that commemorate the Health Awareness Days. And then when it comes to our equity target, these ones are still challenging us. We had a target of 50 women employed at senior level in the NDOH, and we achieved 47.5. And the 2.5% that we missed was because of transfers, promotion, retirements, and cost containment measures that were in place, as we couldn't fill some of the posts even. Then when it comes to youth employment, we had a target of 30 and we reached 6.8% for this financial year. This was due to the cost containment measures in place. However, for this financial year, it looks like we will have a better performance in this regard, as we are having the interns being coming on board. And then when it comes to target of 2.5% of people with disabilities, we reached 0.1%, and partly because of the non-disclosure on the Z83, but also the pool that we seem to be dealing with is limited. So the strategies to deal with areas where we did not perform well. So when it comes to the 30-day payment, we have addressed the issues of suppliers, banking details, and investigations where there was a default on the side of a manager has actually taken place in terms of addressing the issue. And then when it comes to staff equity targets, we are engaged in filling the critical vacant posts in line with the employment equity requirements. We have amended the recruitment and selection strategy and also revised the turnaround time for appointments such that it's more efficient. The prioritization of internal promotions for youth is also in place to address the shortfall on youth employment. And we are implementing targeted recruitment interventions for people with disabilities. Then coming to the program 2 on national health insurance. So we had a target of 9.5 million parcels delivered to pick-up points for the Central Chronic Medication Dispensing and Distribution Program. This is the program that has ensured that people can easily access the medication in their close-by outlets, including private pharmacies, where they don't have to always going to the clinics. So here we have reached 8.9 million, and really here what affected us was the program capacity, which was reduced as a result of the United States government funding withdrawal. However, we are happy that we are implementing this multi-month supply as we moved from 2 months to 3 months. Then we are now working hard towards the 6 months. And then when it comes to the accreditation framework for health providers submitted for approval. This has been drafted. However, there were delays in terms of consultations, so it has not yet been approved. So here we show the numbers of parcels that are being delivered, and with the most of the pickup points appearing in Free State, in Eastern Cape, and then Mpumalanga. So, which is encouraging, as we know that these provinces are also vast and they are in need of these services. So then the next target was on the capitation model and methodology framework that needed to be developed, which was achieved. The next target is on the development of electronic medical record minimum viable products, focusing on TB and HIV, which was also achieved. The next target is on the essential equipment list for healthcare service package, which is a critical component of our work in delivering the services, which was also achieved. So really, in terms of the CCMDD program, we are continuing to provide the 3-month supply and increasing the patients served according to the funds available. Then coming to the third budget program, communicable and non-communicable diseases. So in terms of the target here, it was 3.3 million HIV stable clients decanted to differentiated model of care. And with this one, we achieved 2.6 million. And the challenge really in reaching this target was the fact that provinces such as Mpumalanga, Northern Cape, and the Western Cape had low decanting rates. And also some provinces, Free State, KZN, showing some decline compared to the other quarters that in the current financial year they had to work on. And then when it comes to youth zones, we had a target of 2,200 and we reached 2,166. We didn't reach the target because Northern Cape removed all the facilities that are not fully implementing youth zone program from the list. And also there was a challenge with reporting consistently in Limpopo and KwaZulu-Natal. And so in looking at the numbers of clients across the provinces that are enrolled in this differentiated model of care for HIV and AIDS, it's quite important that they are able to get their medication through this distribution. And so we can see that Gauteng is leading, which is in line with the fact that they are the biggest province, followed by KZN, and then the other provinces follow thereafter. In terms of the distribution for youth zones, in terms of the provinces with the PAC facilities with youth zones, here we are showing that the Eastern Cape is taking the lead, and then followed by Gauteng. So, but in terms of probably the numbers, I guess it's about reflecting also the vastness of the provinces and ability to actually to reach for the youth zones. And then when it comes to TB, with the blend targets of 83% for the drug susceptible TB clients successfully treated that we were able to reach. When it comes to drug resistant TB, we slightly exceeded by 0.8 with a target of 73, getting a 73.8. And we had also a target of 221,941 people started on TB treatment, and we reached about 180,566. The reason for that being that some of the patients became initial loss to follow up or die before they could start treatment, something that is being dealt with in the plans that we have for the current financial year. So here, I think what we also showing here is just the distribution of the TB, drug-susceptible TB treatment success rates, in which there are a few provinces that went beyond the target of 83%, which will be KZN and Gauteng and Mpumalanga, and also the Northern Cape. But we do have still a challenge in the Western Cape in terms of the achievement of 66.5%. So the trend with regards to the drug-resistant TB, we can see that the Northwest is doing well here at 86%, and also we can also still note the same challenge being the last one, the Western Cape. And then when it comes to the districts that introduced HPV screening for cervical cancer, we had a target of 18 that we exceeded, with a better uptake in various provinces. And then when it comes to the districts with non-polio acute flaccid paralysis detection rate of greater than or equal to 2 per 100,000 among children less than 15 years of age, we had a target of 45 districts. When we reached 39 districts, this was partly because of the capacity that was limited, some of the districts lacking the surveillance officers for us to be able to fully meet the target. And then when it comes to malaria, in terms of the target, it was 40 sub-districts implementing FOSI clearing program to monitor the malaria, and so we reached that target. And then when it comes to screening for diabetes and hypertension, we have exceeded both targets for this financial year due to rollout of things like NCD campaigns in the provinces. And then when it comes to state patients that are admitted into designated psychiatric hospitals, we had a target of 200 and we exceeded it. We reached 408. We had a very much strong follow-up and support to the provinces to be able to exceed this target. In terms of our campaigns, the 4 national non-communicable disease campaigns were conducted. In terms of the number of hospitals that are compliant with food service policy, we had a target of 351 and we reached 358, exceeding the target. So for the targets that we did not reach, so in terms of improvement, we conducting the thorough investigations into the provinces that have struggled with meeting the targets, and also rectifying some of the data issues that emanated from that. We also have been conducting the webinars with the provinces. For the youth zones, again, the verification of information, and also the issue of establishment of youth zones in Limpopo and KwaZulu-Natal had been addressed by the Director General with the leadership of the provinces. In terms of the TB, we are implementing the short message system notification to notify patients about their results, and also verifying and cleaning up the data at a district level. In terms of the polio detection rate, we are intensifying capacity building for surveillance and also conducting supportive supervision. And lastly, most important as well, is also advocating for increased resources, such as the availability of surveillance officers. And then coming to budget program for primary health care. So we have the first target on 25 district hospitals qualifying as ideal hospitals. We reached 7 of those. And the challenge, really, the capacity became an issue within an environment with constrained resources, including the budget. And then for the ideal clinics, we had a target of 2,700, and we exceeded it to reach 2,762. And then when it came to the community outreach services household visits, these are the visits that are conducted to the actual household with the community health workers. We had a target of 14 million, which we reached more than 20 million. And then breaking down the figures on the ideal clinics, what we are showing in terms of this slide is that we are overall, for the current numbers of primary health care facilities, we are at 80%, and the lead provinces in this regard is Gauteng, KwaZulu-Natal, Mpumalanga, also Free State, all these and Northwest, all these provinces are above 90%. And then the provinces that are at the bottom at the moment would be the Eastern Cape and the Limpopo. But the overall is at 80%. And then in terms of the hospitals that that qualified as ideal, these are the hospitals in Free State, in Gauteng, KwaZulu-Natal, and Limpopo, with their names of the facility indicated as well, the district hospitals. And then when it comes to the community outreach services to the household, we have got most of these numbers in Gauteng and KZN. I suppose it also, the fact that they also have more population, but also in terms of the community health workers, the numbers themselves, KZN is just above 9,000, and Gauteng is also having high numbers. So, but it varies across the other provinces with, as expected, I suppose, with Northern Cape still having lesser numbers. So when it comes to the indicator on revised assessment tool developed, so this one was achieved, which then addresses the issue of municipal compliance with issues of environmental health. And then when it comes to the to the target of 10 metropolitan and district municipalities assessed for compliance with environmental health norms and standards. We achieved this target. Same with compliance with regards to regulations relating to standards for emergency medical services. So in order to push the work for the ideal hospitals, the National is prioritizing the filling of vacant posts for the program that is responsible for the ideal hospital initiative. Coming to the fifth program, hospital systems. So here we had a target of draft hospital strategy finalized, and the achievement was that we had this developed. However, upon it on its way to approval, the Tech NHC wanted the implementation plans for each province to be developed, which required further consultation and time for finalization. And when it comes to the National Health Quality Improvement Programs, we are currently at 93% in terms of its implementation against the target of 100%. We had a challenge with one central hospital delaying the loading of the assessment results in the system, and also there was a closure of some TB hospitals. And then when it comes to infrastructure, so for infrastructure, we had a target of 42 primary healthcare facilities constructed or revitalized, and we exceeded this target by 47. And when it comes to the target of 50 hospitals constructed or revitalized, we had a target of 50, we reached 46. So the challenge there was the revitalization work in the operational hospitals taking time, and 4 of the projects failing to reach a completion stage. And when it comes to the target of 400 public health facilities, that includes the clinics, hospitals, nursing colleges, EMS base station, maintained, repaired, or refurbished. The target there was 400, and we exceeded it by 3. So in terms of addressing the issues of underperformance, the strategy is prioritized for the current financial year 25-26, and for the public hospitals implementing the National Health Quality Improvement Program, the provinces will manage their databases to close and remove the TB hospitals. We have got the health facility. We have got the health facility master facility list, and we are actually making sure that the facilities are being updated on the system, and then we are conducting the monitoring visits to ensure that the results are uploaded on time. And when it comes to construction, we continue to work with the provinces and monitor the work that is being done, and ensure that penalties are being applied where the contractors are failing. So the last budget program will be the health system governance and human resources. So with this one, the first target was the appointment of the South African Health Products Regulatory Authority, SAPRA, for a new three-year term. So in terms of this target, we were able to, the term for the current board was actually extended, and the call for nomination happened towards the end of the financial year. However, as we sit now in 2025, this board now has been appointed after the end of the extension 30 June 2025. And then when it comes to the National Health Laboratory Services Board appointment, this has been done. When it comes to the South African Dental Technicians Council appointment for the new 5-year term, this has been achieved. And then when it comes to the audit action plans for the entities, we had a target of 5. However, because the MRC, Medical Research, South Africa Medical Research Council, and the Office of Health Standards both obtained clean audit outcomes, so there was no need for audit action plans. So hence then we missed the target by 2 because of the fact that only 3 actually at the end needed to have the audit action plan. And then when it comes to the 9 differentiated nursing education and training plans developed, this was achieved. And then the next one is on the draft set of final food labeling regulations submitted to legal services. The process commenced. However, there were delays because there was an extended comments period which required further consultations. So the strategies to deal with areas we did not reach the targets. So the issue of SAPRA has been finalized in 25-26, and the food labeling regulations have been prioritized for this financial year. So, Chairperson, when it comes to the overall performance, we are indicating that overall for this financial year, we achieved 62.8%, and the breakdown in terms of the budget programs is also indicated. So I'm going to cover just one more slide on the human resources. So in terms of the, and these are the posts at the national, so we have got a total of 977 posts on approved establishments, and we have got 832 of those filled, which leaves us with a vacancy rate of 12.1. So I will stop here, Chair, and the Chief Financial Officer will continue from here. You are muted.
Thanks. Yeah, thanks, Askisa, I was muted. I'll continue with the presentation from where she ended, Chair. I'll also switch off the video, then I'll continue with the presentation. In the year 2025, as the Department of Health, we have 6 programs. I think she already went through the 6 programs in terms of the non-financial information. So the total budget that we had as the department, it was 62.2 billion rand. So that talks to the final appropriation that we have. And there was the actual expenditure by the 31st of March of 61.8 billion. And then there were funds which were not spent of 343, and the total spending for the year, it was 99.4%. So I'm not going to go in terms of each program on these slides because there are still other slides where we'll have the details in terms of the sub-programs. The next slide, then we show the same summary in terms of the economic classifications, our compensation of employees. We have been funded by 692 million, and goods and services were sitting on 1.6 billion. And the transfers of 58.4 billion. So on the 58.4 billion, Chair, and that's where we also support the provinces and the NDT supported by the department. So there will be, towards the end slide, indicating the conditional grants and the allocation per each province. And then we also do have the capital of 1.4 billion. That's where the national department is also implementing some of the project under program 5, which have been already presented. So the next slide, we're just showing in terms of the reasons, more especially on our compensation of employees, that there were slight delays with recruitment, which have resumed after the May 2024, following the approval from DBSA to fill the identified critical post in the department. And also under goods and services, there were several reasons, like our procurement for Microsoft professional services was still underway. And also there were other services that we have submitted to CETA. So there was delays and some of those were not completed. And some of those, they were re-advertised as there were no suitable bidders, which were identified by CETA. And there was also a budget under our communication strategy where we have managed to spend 45% by the end of the financial year. But of course, we were still implementing some of the campaigns. And the money that we have made available for paying the CSIR, so that's under the patient information systems under program 2, which is our NHI. We also had the money which was not spent, and also under capital, because some of those relates to capital under information technology. So the next slide then, Honorable Chair, we just then show per each program, like our program 1, we do indicate the sub-programs within the program. Then our total budget was 702. So I'll only consider the final appropriation towards the middle of the table. It was 702.9 million. And we also did spend, so in terms of the percentage, we're sitting on 91.8%. So that's where, because it's a support function in terms of paying the Microsoft and also the IT-related procurement. Under program 2, which is our NHI, I think some of the reasons they were already indicated, but in this program, in the last sub-program, which says National Health Insurance, and that's also, we have in the conditional grant where we're supporting the provinces with mental health and also the HP contracting, but we'll also indicate the total amount as we proceed with the other slides. Program 3 is a communicable and non-communicable disease. So it's our biggest program, because that's where we also find in the HIV and AIDS. You'll see in the middle, we have a budget of 25.1 billion, which goes to the sub-program for HIV and AIDS. And the total budget in this program, it was 25.4 billion. And we did spend 25.4 billion with the 99.9% spent. So that's 100% good performance. And in program 4, which is our primary health care, we also supporting other programs in the provinces like our CHWs, which is community health care workers. That is the amounts that we have under district health services of 3.2 billion, which we did spend the whole funds in terms of that sub-program. And in this program, and also we have reached the 99.49% in terms of the total spending. Program 5, which is our hospital services, the sub-program, which is in the middle, that shows the health facility infrastructure management, the allocation of 8.6 billion. It's made of 2. There is around 1.3 billion that we find in the indirect conditional grants. Those are the programs implemented by the National Department of Health. We also did have 7.1 billion of that conditional grants going to the provinces, and the allocation, it will be indicated together with the spending per program, per province. Then under our hospital services, that's where we also find in the national tertiary services with our conditional grant, which we call it NTSG. And you can see the spending, Honorable Chair, has been 100%. Program 6, the national department, we also support our entities. You'll see in the middle, we have public entities management with an allocation of 1.8 billion. That's where we also fund the entities supported by the department. And also the spending was 99.4% in terms of the overall program. Of 7.5 billion allocated, we did spend the 7.5, which is 99.7%. But before I pass on this program, there is a last line item, Honorable Chair, that says Women Resource for Health. That's where we also funding the interns, the ComServe, the registrars that are also in the provinces. but the details will also follow within our conditional grant slides. The audit outcome is the National Department of Health. We just shown for the past 7 years. The next slide, you will see we only got qualified within 2021, 2022, but after that we have picked up. We also indicated the overall spending for the National Department, which we have been sitting on 99.4%, which is more acceptable. And then with our unauthorized expenditure, you'll see it started in 2020 and 2021. They were processed, actually it happens during COVID. The investigation has been done. The documents, they've been ready, submitted to National Treasury in terms of following the condonement processes, but however, it has not yet been finalized in terms of that. And there has not been any unauthorized expenditure since 2020, 2021. With our irregular expenditure, we have been working very hard. Honorable Chair, you'll see from 2021, 2022, the balance, even though it went a little bit up in 2023, 2024, but then we have been working on the cases, making sure that we do investigations and finalize and also do the condonement processes where applicable. And the balance has been reduced to 202 million. So we'll continue to work on that so that we have a zero unwanted expenditures within the National Department. With our fruitless and wasteful expenditure is the same, Honorable Chair. You'll see since 2022, 2023, we have been putting processes in place dealing with the transactions that we have been having, while we have also strengthened some of our controls to make sure that we don't incur in additional fruitless and wasteful expenditure in the department. So the 94,000 that remains is what remains within our books since from the previous financial years. So we'll continue in the next and also ensure that this balance it gets cleared. And then we will follow with our conditional grants. So on our conditional grants, this is the monies that it has been appropriated by the National Department, which we then transfer to the provinces in terms of implementing some of the performance that Sistuli has already presented. So we had the spending of 99.4%, or we can say 56.6 billion against the budget that we had of 56.9 billion, and also compared to previous year where we have spent 98.5%. So there was a slight improvement in ensuring that we spend all the funds which are being allocated to the provinces. At the next slide, Honorable Chair, we then show the conditional grant summary. So in this slide, we show all our conditional grants. So we started with the NTSG. We had the total allocation as reflected, and also the expenditure, and also the percentage per inch. So I'm not going to go in details on this slide, but it's just for honorable members to check the performance in terms of each conditional grant. And also just to take a note that under District Health Program grant, it has the two components. Number one is the comprehensive HIV and AIDS. And the second one is the District Health component, where we find in the community health care workers. And the other one that we have is the statutory Women Resource grant, where we also having two components with this statutory HR resource component and also the training component. But I'll also indicate even the allocation to the provinces as we proceed. So you can see the total and the overall spending, as I've already presented, of 99.4%. And then the next slide, we then show the summary per province. So the total money that has been allocated per each province and how much the province they have spent. But of note in this slide, there's also provincial rollovers. So it means as a sector, we also did apply for rollovers, mainly in Gauteng, 580 million. And it has been approved and the money was given to the province. But the total, you see, it was 604 million. In terms of what we have received, and we went to our adjusted budget of 65.9%, 56.9% as I've presented earlier with the total expenditure. And then on the next slide, Chair, that's when I said we will still have each conditional grant with these allocation per province and the spending per province in terms of our NTSG. Those are the allocations that we had to all the provinces. You'll see, of course, Gauteng with 5.6 billion, followed by Western Cape with 3.5 billion, and also KwaZulu-Natal in terms of the biggest allocations, because that's where we have most of our tertiary hospitals and central hospitals in the country. The spending, it has been 98.2%, and you can see compared to previous financial year, we have improved in terms of the spending because we were moving from 95.7% to 98.2%. And the provinces, they've performed well. Of course, the Gauteng chair, you'll see the spending there was 96%, but it's also because we had the rollovers, which I've previously indicated, which were approved. And then the next grant is the district health program grant. You'll see in terms of the spending, it's almost 100% and 99.9%. So it has been performed well. So we do have the two components. On the next slide, we start with the HIV and AIDS component. You'll also see, in terms of each province, the spending, it has been 100%. We only had Gauteng with the 99.6%. And then with the district, the health component, it's mainly the HR. On our community healthcare, CHWs, community health workers in the provinces that they've been deployed. So the total budget that we had here was 3.2 billion, and we did spend all the money. So there was only 5,000 that was, 5 million that was left at the end of the financial year. The HR, which is statutory human resource, and also the training grant. Also, you'll see the spending. It has been sitting on 99.5% from the total allocation that we had, which is 5.5 billion. But on the next slide, we'll start with the statutory HR with the allocation of 2.5 billion, where we had spent a little bit with 1% additional, Honorable Chair. And also with our training component on the next slide, where we also show the spending of 100% in most provinces except the Gauteng and Eastern Cape, sitting on 97.9% and also the 90.8% respectively. The next grant is the Health Facility Revitalization Grant. That's our infrastructure, the money that we give to provinces to maintain the infrastructure and also build other new facilities in the provinces. The allocation budget, the adjusted, was 7.1 billion, and we did spend 100% in terms of this grant. Honorable said there has not been a challenge. I think I have not been going through the allocation per each province, but then I take it that honorable members will also note that in each of those grants that I was going through, there is an allocation per each, and also the spending that we have reflected in the percentage. On the National Health Insurance Grant, on the next slide, this one, it has two components, but they are not being separated. The first one is the mental health component, where we also assist in the provinces to acquire the mental health expertise to assist us within the different facilities, and also the HP contracting, our health professional contracting, to make sure that we can perform the outreach services in our primary health care facilities. So they have been funded within this grant in the total of 471 million, and the total spending that we had of 98.1%. It was just a slight decrease compared to the previous financial year. And then the next slide, which is our last slide, Honorable Chair. Here, just to say, this money is sitting within the different programs in the National Department. We have shown the first one, for instance, the 1.4 billion on the infrastructure, the one that is assisting us to build some of the hospitals, including Limpopo Central Hospitals, the Siloam, and I think some of those hospitals, they were also indicated in the previous on the non-performance. And we also have the health system component, where we also strengthening the health systems. I think the program 2, there was a presentation in terms of the numbers on the CCMDD. And we also do have the numbers where they've also been presented on the ideal clinic component, where we are also supporting the provinces, and also the patient information systems within the NHI, where they are building the patient information system so that it can assist the sector in terms of the service delivery. So it's all those ones that we have, Honorable Chair. where we also have the medicine stock, civilian systems, supporting our CCMDD, our RX solution, and other solutions which are in the provinces to ensure that we can manage the medicine appropriately. So those are some of the indirect grants that we have. So I will hand over back to you, DG. I think that was this last slide. Thank you.
Thank you very much, CFO. Thank you very much also to Tuli. We hand back to the Honorable Chair. That's our presentation from the department.
Thank you very much, DDG and CFO for the presentation. It's really appreciated. Honorable members, we have received the presentation. Can I get your hands in terms of contributions and questions? Honorable Duplessis, your hand is up. You can proceed.
Thank you, Chair. There are just a few questions that I have. However, first and foremost, it looks good that it's an unqualified audit, so it is a step towards better health within this country. However, there's little reporting on the extreme budget drainage of the medical legal cases. Part of this is, has any real data and analysis been done on these medical legal cases? What is the case management system, and what is the planning to ensure that these cases do not recur within a healthcare system that seems to be creating a lot of medical legal cases, which to me is indicative of a system that is not functioning at its fullest capacity. I would also like to find out what the plan is with regards to the accruals within the AGSA report. The majority of the provinces had incredibly high accrual rates. Why did this happen? If there are provinces who were able to not have this happen, and what is the plan for the accruals? Because both the accruals and the medical legal cases are budget drainages, which often impacts cost containment measures, that impact hiring, that impact a lot of other parts of the healthcare system. I would like to find out what has been done with regards to the NHLS understaff, or the fact that NHLS has been reported to be understaffed. Then with regards to people with disabilities, why is this happening? Because it cannot be new. It cannot just be in this year past. And the reason why I'm asking is I've heard various reports in different provinces with regards to nurses or medical staff that have psychological diagnoses, yet they are often bullied within the system of healthcare, and mental health is not taken seriously, and wellness is not given directly to people with unseen disabilities working within the system. So I'd just like to find out about that. Then with regards to youth employment, the aim is 30%, but 6.8% is much lower than 30%. It cannot be that the only reason is the cost containment. I'd like to have slightly more details on this and what is being done to ensure there was a mention of interns being included, but if we're looking at entry-level community healthcare people, these are usually people within the age bracket of youth. Is there a lack of training for them? Is there a lack of excellence? Is it, or what are the additional problems? Because that would be a question. Then with regards to food quality, how do you measure food quality? Is this dependent only on the hospitals and clinics giving you data? Then the ideal clinic data is incredibly exciting unless you've been to the clinics in the province that I come from, which is in Gauteng. And I cannot believe that there is a 90% ideal clinic rating unless, I don't know. I'm incredibly concerned about that because the clinics are still overcrowded. The clinics are still not functioning to their fullest capacity unless the ideal clinic rating is not sufficient. And then that is a conversation that needs to be had. And Chair, through you, if it is possible, or I will just ask a written question with regards to the list of the ideal clinics within Gauteng so that we can, or I can do oversight on these clinics to see that. Could I get slightly more, or could we get more information regarding the closure of the TB hospitals? It was mentioned but not explained. Then the virulence in administration is incredibly high in the administration program, if that can be explained. And then what is being done to ensure the monitoring of conditional grants and that these conditional grants make a difference for the people on the ground and aren't just paid as habit? Then two last questions. Is the Department of Health ensuring that people, and it's a question asked before, but I'm not sure if it's happening, ensuring that the patients and residents are aware of the referral system? This will minimize a lot of the shortages in the drug shortages in some of the clinics because people are not going to the correct clinic or hospital to get their prescriptions. And also knowing which way to go or where to go specifically can have patients understand their rights within the system as well and what has been done. And then there's no reporting on progress on the e-health system. It is a budget item. Quite a lot of money has been spent over the past few years, past few decades on e-health. It has one or two successes, but we have many more hospitals and clinics than 10. So I'd just like to get an update on e-health as well. Thank you, Chair.
Thank you, Honourable Du Plessis. Honourable Makwele, over to you.
No, thanks very much, Chairperson, for affording me the opportunity. Let me welcome the presentation, maybe through all the presentation presented on behalf of the department through the DTG, and also to welcome the extensive and comprehensive report, even from the finance point of view and everything. Chair, maybe I will not touch where my colleague touched. He tried to cover me on some of the questions that I want to ask. But Chair, let me also appreciate the department from moving from the West audit opinion in the previous financial years to the better audit opinion, which is unqualified, which is not that 100% good, which we also wish that the department they need to work very tirelessly to make sure that when we look at this department as is the Department of Health, we must always get clean audit so that it might be an exemplary department. But Chair, maybe the question that I want to ask regarding to the issue when they were reporting with regard to the community engagement, they were giving us the stats as province per province, which we indicated that in the main those provinces which doesn't have more population like the Northern Cape, they show that the statistics they look a bit lower. But what I'm suggesting that instead of them reporting to us in terms of the number of people visited, which their number is fine, but it is also more important that if they can give us the report with regard to the percentage, so that we are able also to encourage those provinces who does not have a large population like your Northern Cape, because if, as honourable members, we only get that, yes, Northern Cape was able to visit such number, which is look like is very low, but we are unable to see the percentage in terms of performance, because it seems to me that we are not comparing them objectively. So that's my suggestion there, but maybe they will clarify us on that. But with regard to the issue of fruitless and wasteful expenditure, which I've seen that when they were reporting in some other years, the fruitless and wasteful expenditure, it goes down. But in other instances, the same place where it goes down, now it goes up. So I just want to check about, I know maybe honorable members has also touched on the issue of control measures. Because remember, if we go up and down, it shows that there is no proper planning, or there is no what we call consistency. Because remember, when we have fruitless and wasteful expenditure, that fluctuates, that goes up and down. Remember, it shows that there is a problem with the issue of control measures. But the issue of consequence management, which I was very much impressed when they were indicating that where there are problems, they implement consequence management. Maybe, Chair, let me just pause here so that I can allow other members, even though I've got a lot of issues that I want to raise, so that I can allow other members so that we can share the issues. And thanks very much for affording me the opportunity to make a bite in this regard. Thank you.
Thank you very much, Honorable Makwele. Honorable Sibande, you can proceed.
Thank you, Chairperson. First of all, I'll start by following my colleagues to thank all presentations which is given to us, but nevertheless, let us go to it. Chairperson, first thing, I wanted to appeal to the department that in future, not for the first time, they must minimize of using acronyms. I'll put an example. The last presenter was talking about CMDD. I can indicate a lot of acronyms. We are the members of parliament who are not working in the department directly as per se. So that you can be taken on board, so that you can be able to interact with them. Secondly, to the department, I wanted to find out from you, thank you very much. In our visit in the Northern Cape has exposed a lot of things. There is a state-of-an-art hospital, which is a mental health care. My worry is one with that hospital. It's correct, don't underestimate it, but why is not converted maybe to be a healthcare hospital rather than to be a mental health care? Because it's too big, that structure, and it's empty. There are a lot of blocks which are not being utilized. And what is the challenge is that automatically, in fact, some of the structures which are not being utilized, they become dilapidated. So their standard is degraded by nature sometimes. So in order for us to be able to steer up that concept of the government, of the NHI, I'll request that maybe if something can be done to look, whether it's a donation, whether it's built by the government. I mean, there's no single person who can think about that, because our legal experience is that in most of the areas there, people are still struggling in terms of the hospital things. And then comes to the question. So person, I would be happy, because no matter what result were being found by the department, but the AG, Auditor General, still consists and manage some. For an example, he mentioned about the issue of the management, that it did not review and monitor compliance with the applicable laws and regulations. I mean, I think something must be done on that regard. And then, leaving that, I will leave that part of the Editor General, go to some of the questions which I've managed to shortlist. How is the department dealing with the accruals, which is a recurring issue in the health sector? And then also, how is the department coordinating with the provincial departments on improving their ability of performance information? And then also, I'll be very much grateful if the department can update us, update the committee on the medical legal case management system. And then another thing which I wanted you to find out from the department, where is it? Has the department blacklisted the non-performing contracts? Let the department give us details, because our legal experience in some of the things we have discovered, some of these things, that some of the contracts, they are not finalizing, finishing their structures, they leave it like that. If the department give us some of the information about that. And Chairperson, let me leave there so that I can allow other people to come up with something. But nevertheless, that one of Northern Cape, I request that something must be done so that we can be able to utilize that particular section, because it is a state of the art, but in the bush, without people, with few people, handful, not even handful people. Thank you very much, Chairperson.
Thank you very much, Honorable Sibande. Honorable Kennedy.
Thank you, Honorable Chair, and thanks for the presentation of the department. I have two questions here. The first one is in connection with operational pressure on primary health care mentioned in the department APP, operational pressures like inadequate technology equipment, long patient waiting times. There is this so-called red zones of EMS. EMS staff facing safety concern in red zones being areas with high trauma and gunshot incident, for instance, requiring police escorts, which can cause delays, etc., and the staff shortages, vacant positions, and financial constraints. So the question is, what is the question is, how are these operational pressures on primary healthcare, emergency medical services, and forensic pathology units being addressed as mentioned in the report? My second question is concerning the AG's report under financial and financial performance. What is the progress on the AG's general recommendation for corrective action, and how will their implementation be monitored? Thank you, Chair. That's all.
Thank you, Honorable Kennedy. Thank you, honorable members, for all your questions. DG, from my side, I just have a few questions in terms of the presentation. First and foremost, the AG also reported last time on the 5th of November 2025 that as a department, especially in the provinces, there is no maintenance plans in place. So I will just check with the department if you can give us an update on that one. The members did cover me in terms of the accruals, and then in terms of, they also indicated to us that the ideal clinic indicator were not included in the APPs of some of the provinces. What does the department do to monitor this, the APPs of the provinces in terms of this indicator? And then in terms of the, in the presentation, the department indicated that they are monitoring the audit action plans of the entities. Are there such plan in place to also monitor the audit action plans of the provincial departments? And then in terms of the performance target, the achievements of the targets, as the department, it indicated that it is at 62%, but the spending in terms of actuals is 99.59%. So if you can just indicate how can you spend all the money, but all the target is not met. And then in regarding, let me just get this one. Regarding the role of the health patient registration system, is the HPRS fully functional across provinces? What are some of the challenges challenges to it functioning effectively? And then in terms of the EMS services in South Africa, can the department please give us an update on the services? Because when we went to the Northern Cape on our oversight, most of the hospitals indicated that they have an issue in terms or challenge in terms of EMS. And then in terms of the given the high rate of sexual crime in the country, how many health facilities are designated to render services for the management of sexual and related offences in the country? Can the department please elaborate on that one? The last one, DG, is in terms of how does the department measure the success of health promotion messages that is sent out? What is the mechanism that you measure it against? So that is from my side, DG. So over to you to respond. Thank you very much, DG.
Thank you very much, Honorable Chair and Honorable Members, for the questions. We really appreciate them because from our side, it shows that members are listening well now during the presentation. I've classified the questions because we've got relevant managers that are here with us. There's questions that have to do with medical legal, with accruals, with Auditor General's findings. Yes, mainly, and also the audit action plans for provinces. I'd like to request the CFO to deal with those questions. And then there's quite a number of questions that are on primary health care, including IDR clinic, and the number of areas that are around the primary health care. I'll ask DPG Hunter to follow the CFO, then I'll call the other members. CFO, over to you.
Yeah, thanks, DG. I'll go through the questions. I tried to combine them where possible because some they were similar. I'll start with the question which was asking about the accruals. I think in the main, the reason why the accruals is continuing to be a problem with the sector, but maybe to also indicate from the previous financial year, which was 2023-2024, we were sitting on 21 billion accruals, and in 2024-2025 financial year, which is the one that we present in the annual report, we were sitting on 24 billion. So members can also realize that these accruals, they are increasing. And we have also indicated that the public health sector has suffered a consistent underfunding across all provinces for many years. And even though there was a bit of an improvement, which we have realized during the COVID-19, because there was the funds which were allocated or appropriated specifically to deal with the COVID. So there was a slight improvement. Now, the also part of the challenge is over the years, you will note that the COE, it has also continues to be a challenge, whereby the budget that we were receiving in real terms, it was not an increase because it was way below the salary adjustments that we were getting. It was way below the medical inflation because we rely on the payment of medicine and other commodities to support the provinces and the patients in the country. And even the construction index increases, they were way above the increases that we were receiving as a sector. So therefore, I think that was mainly some of the cause, and I think I've given the numbers. And I think I do have the numbers for the past 5 years. And so in terms of what has been the increase in the accruals in the sector. So that is the increase it has been there. Also, the members, they will know that as a department, we have lobbied the Treasury to try and assist the sector to improve the situations. And we also know that the Minister of Health, during his budget speech, he has announced an additional funding allocation for the health sector over the MTEF of 20.7 billion. And amongst what the Minister of Finance has sent, it's also to assist the sector to deal with some of the accruals, which, Honorable Chair, it was followed by the Minister of Health, Dr. Arun Mutsoledi, when he has done his budget speech also. He has indicated some of the priorities which were identified by the National Health Council. And in some of those priorities, it also includes the payment of accruals or the reduction of accruals. And in the main, he has mentioned, amongst others, which we're having a challenge to make sure that we can manage our oxygen that we have dealing with our medical equipments, because most of the service providers, they will also complain the issue of the lab services, which we do through our national health lab services, and also even the blood services and even the medicine in general. So we have tried and ensure that we communicate with the provinces to ensure that they allocate additional funding to deal with some of these which are within the goods and services. Because over the years, as I've said earlier, when the real increase in the sector, when the increase was not really above what we were getting in the COE, then when the COE budget increases, goods and services will then suffer, because as a first charge, we have to make sure that the employees are adequately funded within the sector. And then just wanted to also combine the same question with the issue of fruitless and wasteful expenditure, more especially for the National Department of Health. I think as I've presented the decrease that we have been realizing over the years, we have ensured that we improve our control measures within the department. Even in the report that Tula has presented, she has indicated that even in the previous financial year, on this annual report, we only had 7 invoices out of the 2,571 invoices which were paid after 30 days, because in the main, also the fruitless and wasteful, it will come as we have been unable to pay some of these invoices within the required time frame. And we have paid a couple of those invoices. So this 7 is because there were reasons, and some it would be because we returned them to service providers to fix some of the issues within the invoices. And also, Honorable Chair, on that fruitless and wasteful expenditures, I was indicating some of those controls that we have to ensure that we pay our invoices within 30 days, make sure that we support all the SME, all the small businesses by ensuring that all invoices are getting paid. Actually, our invoices, they get paid within 7 to 10 days when we check on the average. But also there is a member who also inquired with regards to compliance with laws and regulations. So that is a move in the right direction as a sector, and making sure that we comply with some of those regulations, ensuring that we make payments as they're required. So some of those that were reflected by AG in our previous audit reports and annual reports in the past, there will be compliance with laws and regulations because of payment of invoices not within 30 days. And then we realized that in our audit report in the previous financial year, that non-compliance, it has been removed because we have ensured that we comply. I did indicate within irregular expenditure and fruitless expenditure, we do follow the consequence management, but we also did have a non-compliance which was raised by AG because not all cases were finalized in time. And we continue that we make sure that we finalize the remaining cases so that we also because the non-compliance at this stage, Chair, is the one that will be sitting between the clean audit in the department, more especially in terms of the finances. So we're just trying to clear some of those non-compliances to make sure that we can move to clean audit. There was a question on the blacklisting of companies. There is a lot of companies that we're dealing with, more especially those who are also assisting us in the infrastructure. But the colleagues, they might also give more details. There are also companies where we have terminated the contracts because of poor performance. But in terms of blacklisting in the National Department, we did not have any companies that we have blacklisted in the previous financial year. But the member was rightfully making the comment also relating to the provinces, which we can get more details from the provinces to assist in terms of providing the details of information that was provided. I mean, the companies that were blacklisted. There is also corrective actions that was mentioned that we must, what are the steps and what are the actions plans that we have? Honorable Chair, as a sector, we have established what we call 10 by 10 with the Office of Auditor General in the previous financial year, and actually 2 previous financial year. So that is a helpful platform because we do have all the offices of AG in the country, in the 9 provinces, including the National Department. And we have the CFOs in all provinces that we come into one room. And then we deal with some of the inconsistencies that we're having in the sector. We review and monitor the plans that we're having because it will be very difficult for the National Department to be in a position to monitor each province. But however, through those platforms, we are able to monitor the progress that the provinces they have done. The next meeting that will be held in this regard, it has been planned now in January and February 2026. I think it's because currently AG is finalizing their audits in terms of the municipalities. We also do have the CFOs Forum, which we have scheduled one on the 11th and the 12th of December, where we also meet with all the CFOs in the provinces to present the progress that they have in terms of clearing the common issues that we have realized in the audits, and assist one another to ensure that at least we build the controls in different provinces to improve the audit outcomes. And Chair, because there was also a mention on the medical legal, just to also congratulate the Eastern Cape. We know that they have been qualified in about 3 previous financial years only on medical legal. So the province, they have also worked in terms of their registers, put a lot of controls in terms of managing medical legal cases in the province. We do acknowledge that we can't undo what has been done in the past, but going forward, there is case management that we also centrally at the national department make sure that we have the provinces to capture the information in a single platform. So we're still getting them. But I think in terms of the prevention of medical legal, it's more of clinical, which I think the colleagues, they will assist in terms of some of the controls that they have put in place to ensure that we don't incur these medical legals going forward. There was another comment, DG and Chair, relating to youth employment. We have noted, firstly, just to start with the CHWs, of course, yes, even if they will be appointed permanently, they might not address the issue of youth employment because the CHWs cadres that we have in different provinces, they are in different age groups, so they are not necessarily within the youth. But we did have, as we were reviewing our internship program, we wanted to double the number of internships that we have so that also as a health sector in the national department, we can be in a position where we train the youth that we have in the country through the internship, and also it will assist in terms of the youth employment and making sure. And also, DG, just to mention, I know it's a DPSA circular that has been issued in terms of early retirement. We also believe that process, it will assist the department because we might be having some of the employees that takes the handshake, and so those are the ones between the age of 55 to 59 or 60. So then we will be able, or we will be in a position to employ some of the youth to join the department. The monitoring of conditional grant, it goes the same, because where it starts with the monitoring of conditional grants, all the business plans that the provinces, they do with their HODs, as they finish, they come to national department for DG to be able to review together with the conditional grant managers. And after it, there is a program where we do go to the provinces and monitor the targets that have been achieved against the planned targets which they have in the business plans. And also in the past, in the previous financial year, we have requested that the provinces, they also develop the annual procurement plan aligned to the conditional grant business plan, so that then we are able to monitor where in the stages the procurement stages are, to make sure that at least we can push the provinces to achieve some of those planned targets. And I think in those, Honorable Chair, we have discouraged any province to be planning to do procurement of items during the 3rd and 4th quarter. We believe that the specification and all other processes that the provinces must follow, they must be done within the 1st and 2nd quarter, so that only in the 3rd and 4th we're dealing with the implementation of what we have planned in the sector. So DG, I think I've covered, if I have not covered some of the questions, I think you'll also indicate, then I can come back. Thanks, DG.
Thank you very much, CFO. May I invite DDG Jeanette Hunter to deal with the related questions for primary healthcare and other areas. DDG Hunter.
Thank you, DG. Good morning to the Honourable Chair and to the Honourable members. The first question that I will respond to is the one on how do we assess food quality at the institutions. We use a tool called the food service assessment tool to when we visit hospitals to see whether they comply to standards in terms of food and food service. This tool has 14 thematic areas. It covers issues of infrastructure, to look at whether the hospitals have appropriate spaces for preparing food or distributing food in case they use a food service company that delivers ready prepared food. We look at the human resources that they have to be able to manage preparation of food where applicable, and then also the safe distribution of food in the wards. We look at the training that staff has undergone, and you look at whether the facility has the required equipment for providing nutritious and safe food. We also look at the temperatures where food is stored, and then also the condition and temperatures within food delivery vehicles. But to get to the actual food quality itself, we look at the nutritional value in terms of either the 5, if you want to look at 5 food groups, or the 3 main food groups. We look at the quantities that serve, service times, and then you also look at the quality of the food in terms of freshness, and also whether the health facility complies with therapeutic diets. Do they appropriately serve, for example, diabetics or people with hypertension with a food that is prescribed for their kind of conditions? So that's with regard to the food services. The next question was on the ideal clinic. And the honourable member was saying that if you look at Gauteng, for example, as a province, they score very high. But when you visit facilities, you don't get the sense of the score of the facility. We are very familiar with this, and the honourable member also used the word overcrowded. And that is the issue. Very early in the program, we learned that people talk to each other, and especially when a facility is ideal, it is perceived to be providing good services. People will bypass facilities that are no longer ideal to visit that ideal clinic. But in Gauteng, we do have a large number of facilities that are truly ideal. And I'm saying we are familiar with this field because we've experienced it ourselves, and I'll make an example of one of the facilities now. In a while, we've experienced it ourselves, and we've looked at this to an in-depth degree. So on the ideal clinic realization and maintenance framework, there's 280 elements. There is an ideal clinic app available from the Google Play Store or even from the Apple Store. I would recommend, if the honourable members don't have it on your phones, please download it, because it then gives you the 10 components and it gives you the 280 elements. And especially, we would also welcome that members actually visit facilities in their areas and see how they agree with the scores facilities have given themselves against the elements that's required to be green in the facilities. Now, I want to use so there's 280 elements. There's about 10 of them that's vital, and there's about 5 that are non-negotiable vitals. And it's only when you fail the non-negotiable vitals that you fail outright. And those non-negotiable vitals relate to whether can you save a life or not. It's about emergency treatment, people who have been injured, or people who are in shock due to something that they are allergic to. And those elements relate to whether they have a well-stocked emergency trolley, do they have the right medicines for emergencies in that trolley, and can they put up drips for people who are in shock, and is there oxygen available? Those are the non-negotiable vitals. So it's actually very enheartening when we look at some of these facilities, how the staff have managed to turn enough elements green in spite of challenges such as infrastructure. And the clinic that I want to use as an example is the Winnie Madikizela Mandela Clinic in Tembisa. We went there with the now Deputy Minister, when he was the Minister of Health, Minister Patla. We visited quite a number of facilities with him. But this was one facility. As we entered the yard, he said, I thought you're bringing me to a platinum facility. This can never be. And the reason is, when you enter that yard, it's just a buzz of people. there are a number of loose standing buildings. And I said to him, it's fine, I know why you are saying this, Minister, but wait till we walk through the facility. So this number of loose standing buildings, quite a number of them are built from this innovative building material. It's what the management, the staff management, the sub-district management and the district management, with the help of the province, could get donations for containers. For example, and many facilities in South Africa suffer from this. They were built many years ago when populations around them were smaller. And especially in Gauteng, populations have exploded, but we have not had the resources to enlarge our health facilities commensurate to how our populations have grown. And this was made particularly difficult through the health's economic situation for the past 5 years, where our budget actually decreased instead of growing. So they would get a container then to do immunization services out of, or they would get a different container to do women's health out of. But if you go through that facility, you will find that they comply, they use the right procedures. They have integrated care where they will see a patient in one consulting room for the patient's diabetes, for the patient's HIV positive status, and the same patient also has high blood pressure. So they will consult people in one consulting room and give all their medication out of that consulting room. They have their equipment and supplies. The only thing they don't have is space. And then some facilities would also suffer from being short of staff. So, Honourable Chair, we would really appreciate members going and giving us feedback, whether it's positive feedback or negative feedback. But we have confidence in our clinics that have scored ideal, because the presidency does visits, independent visits. And whenever they give us a report, there is an 80% compliance. For example, the last time they went, they visited 38 facilities, of which they found 36% complied with that score that we had given them, and 2% did not comply. So yes, problems that we have is infrastructure. We also have problems with files. Because of infrastructure, they grow out of space to have sensible and user-friendly filing systems. And this issue of the filing system will actually only be corrected if the National Health Department can have an electronic medical record, so that we stop accumulating hard copy files, but patients' histories could be then stored on the computer. There will also be better continuity of care for patients when their detail, whether it is demographic or relating to their health, is actually computerized, like it is in most GP practices these days in South Africa.
Sorry to disturb you, Jeanette. Can you just move towards closure? I'm worried about the time for the members.
Yeah, I will, DG. There's an issue of also waiting times, but I'll address it when there was another question on the pressures of primary health care. Then there's an interesting comment that one of the honourable members made about the mental health care hospital in the Northern Cape. And I think the member is looking at this problem with fresh eyes to say, why don't you repurpose this facility for a different purpose? And it makes a lot of sense, because that facility was poorly planned. The way it has so many private wards, you need about 5 times the staff that we have now to manage that hospital properly, because they've got so many closed private wards. It's not an open plan. You then need staff to be able to monitor people in those individual wards. I would actually, we will discuss this with infrastructure colleagues and the management of the Northern Cape, because we have been assigned by as the National Department of Health, assigned by the Minister to assist the Northern Cape with an wrote to the Premier about this, because remember, provinces are very much autonomous in terms of how they manage themselves. I'll move on from that one, DG, to, yes, the same goes with ICRM indicators that's not in the APPs, or let me say, ideal clinic realization and maintenance indicators that's not in the annual performance plans of some of the provinces. We are hoping also addresses this with the provinces, because again, we can only collegially try to convince the provinces to put certain indicators into their annual performance plan. But because they are, provinces are autonomous, we cannot instruct them to do so. Then, how do we measure, let me first, before I go to the measure, how we measure health messages, go to the question on the pressures on primary healthcare services. Yes, there's a lot of pressures, and I've already spoken about the fact that we were really severely underfunded. But because we have this ideal clinic framework, we can actually measure the gaps and systematically work towards filling those gaps. So here I want to talk about waiting times. Most of our clinics have a waiting time of 3 hours or less. And by international standards, that's a very good waiting time, because we cannot turn anyone away ever. I woke up in Geneva with a very sore throat, and I needed to see a doctor because I really needed help for my sore throat. It was unbearable. But because I didn't have an appointment, I waited for 5 hours that day just to see a GP and to get a script for my infected throat. And we have been benchmarking with the United Kingdom in terms of their waiting times. And this is why we know that 3 hour waiting time and less, because we're pushing for less, is a very good waiting time. We're trying to implement our appointment system to get it even better. And we'll continue, and this is why we have this standing relationship with Treasury to always try to get more resources, because it's only with sufficient staff that we can actually bring the waiting times down to what South Africans would prefer. How do we measure health messages? We actually have such an interesting presentation on this. Facebook and X that we use actually measures this. They are also able to tell us which of our messages, for example, is it about mental health, messages about diabetes, and so which attract more people to open and read our messages. We also have a system on these media platforms to be able to answer to people's questions. We have someone assigned to scanning the platforms, look at questions people ask when we put out messages, and also respond to those messages. So we do have reports that says this message had so many hits, so many people actually opened it and read it, as opposed to just scrolling by, or this is the time people spend on this message. And these are the number of, these are the kinds of questions people were asking about the message, and also our responses. Thank you, DG.
Thank you very much, Jeanette. May I ask Dr. Ndlovu, there was a specific question about the closure of the TB hospitals. DDG, Dr. Fikile Ndlovu.
Thank you very much, DG, and good morning to Honorable Chair. I think there was one question on sexual assault, mainly on the post-exposure prophylaxis. All our facilities, 4,000 of them, does offer the post-exposure prophylaxis PEP, what is called PEP. But there is a difference then. Then there are facilities that offer beyond PEP, which is the forensic services that are linked to rape, sexual assault, and those are only 66 in the country. And I think it's a different variation. But in terms of post-exposure prophylaxis, all our facilities are offering the service. Thank you very much.
Yes, Doctor, there was one on the closure of TB hospitals. Maybe Professor Njega can take that one.
Closure of
the closing of TB hospitals. Professor Njega, can you come in? Chief Director for TB.
Yes, thank you, DG. There are hospitals, TB hospitals that are being closed. If you look at the global TB report, DG, you will notice, honorable members, that the TB incidence has been reduced by 61% from 2015 to the end of 2024 in South Africa. Most of our hospitals have a bed occupancy rate of less than 50%. So it's not economically viable or financially viable. That is why the TB beds are being reduced in the country. It is a process that started some time ago. We are monitoring that, and we will be reporting in terms of the progress. Also, most patients are doing very well. We've improved treatment success rate in the country, and there are fewer patients needing hospitalization. Thank you, honorable members. Thank you, DG.
Yes, thank you. Thank you. Then I would like to invite Mr. Moren Nkosi. There was a specific question on HPRS. Please, just a minute to explain. Is HPRS functional throughout the country? Mr. Moren Nkosi, Chief Director in the NHI and the acting PDG. Mr. Moren Nkosi.
Yes, DG, thank you. Honorable Member Chair, thank you very much. Yes, the question was about HPRS. Currently, there's about 3,200 facilities across the country that are implementing HPRS. And also in the Western Cape, there's a different system, but that one interfaces with the HPRS and is fully functional. There are some challenges, Honorable Chair, in relation to the full functionality of HPRS across the country. Mainly that's in relation to connectivity, but also availability of equipment, which is mainly in the form of computers and printing. What the department is doing with the provinces is there's collaboration around training to continuously capacitate the provinces around the functionalities of HPRS and ensure that all the modules in the HPRS are being utilized. There's also been a bit of funding that was mobilized to support some of the provinces that were struggling to get equipment, particularly computers and printers. And then the last intervention in terms of dealing with connectivity, there's been engagements with service providers to make sure that the data used for HPRS is zero rated, and that has helped the provinces in terms of rolling out HPRS. Thank you, DG.
Thank you very much. And then Dr. Ravin Naidu, that should be the last one on the functionality of ambulance services. Dr. Ravin Naidu, are you in the call? Okay, Dr. Ravin Naidu is not on the call, but I would request that we actually submit that in writing. Then the last one was from the member was, why are we spending all the money but we're at 62%? Honorable member, the performance in terms of functional performance versus the budget spend is not actually linear. It's not like if you put 1 rand, you get 1 rand performance. So the inputs that you put, they don't equate the outcomes and outputs. So that is why then it will never be linear in any department that you must perform 100%, then all your budget must also be finished in that way. So that would be the last one from us. Honorable member, we are worried about time. We're sorry we've taken more time than given. Let me hand over back to the Honorable Chair.
Thank you, DG, and the team for the responses. DG, there is there are some questions that is not answered, but through our secretary of the committee, we will send them in writing, like in the staff that the NHLS that is understaffed, and in terms of the personnel, the mental wellness. And then there's another one in terms of the list of the ideal clinics that we want to request from the department. And I think that is, but if there is, they are from the other members that they feel that is not answered.
I am trying to from you want some bread. Let me just get some.
Can we request the participants to please mute themselves? So I think that is all, but we will, through our secretary, send the questions to the department. So thank you very much, DG, for the presentation, as well as the responses from the department. We really appreciate it, and you are released. Thank you very much, DG and the team.
Thank you, Chair and honorable members.
Honorable members, we are now at the point where we must adopt the agenda of the 19th of November 2025. Can I get a mover for the adoption of the agenda?
Honorable Sibande.
Thank you, Honorable Sibande. Can I get a seconder? Honorable members, can I get a seconder for the minutes? Honorable members, Honorable Sibande, move for the adoption of the minutes. Can I get a seconder? Where are the members? Honorable Duplessis.
Chair, I second the adoption of the minutes.
Thank you very much, Honorable Duplessis.
No,
So
we are we're just struggling. We wanted to, but we are struggling. We really apologize for that.
Okay, thank you very much, Honorable Makwele. So the minutes is adopted. Marcia, there is nothing else on the agenda.
No, Chairperson, we finished our program for the day.
Okay, thank you very much, Marcia. Thank you very much to the honorable members for being part of this meeting, and thank you very much to the staff in terms of preparing for this Select Committee on Social Services. So thank you very much. This meeting stands adjourned.
Lekker me voorzitter. Baie dankie vir die dag.
Dankie,
Dankie allemaal.